Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. Today we're diving into the world of drug eruptions, specifically exanthematous, also called maculopapular or morbilliform drug eruption. It is the most common type of drug hypersensitivity reaction. Let's unpack how to identify this condition, differentiate it from more severe reactions, and manage it effectively. This episode is perfect for those gearing up for exams or handling dermatologic cases in the clinic. Let's get started. First, let's talk about the pathophysiology. Exanthematous drug eruptions are delayed hypersensitivity reactions, usually T cell mediated. They typically appear 1 to 2 weeks after starting a medication, or as early as 6 to 12 hours in previously sensitized individuals. Common culprits are aminopenicillins like amoxicillin or ampicillin, sulfamethoxazole, carbamazepine, and clindamycin. A few risk factors to be aware of are genetic predisposition, the administration of multiple drugs, and concomitant viral infections, particularly Epstein-Barr virus, cytomegalovirus, and the human herpes viruses 6 and 7. Presentation-wise, these patients are typically not that sick. They present with an erythematous, symmetric, maculopapular eruption that predominantly involves the trunk and proximal extremities. The rash may involve the face and extremities in children, and mucosal involvement is usually absent. Systemic symptoms are generally mild and may include pruritus, low fever, and mild eosinophilia. And the resolution is usually within 1 to 2 weeks after withdrawal of the offending drug. Now, although, like we said, these patients are usually not that sick, it's essential to distinguish this reaction from other conditions. The differential diagnosis of an exanthematous drug eruption involves viral and bacterial exanthems, secondary syphilis, and rashes associated with systemic or cutaneous diseases like Stevens-Johnson syndrome or drug reaction with eosinophilia and systemic symptoms, also known as DRESS. Warning signs include evolution to erythroderma, high fever, erythematous facial swelling, mucosal erosions, skin tenderness, and blistering. The diagnosis is primarily clinical, based on medication history, timing of initial drug administration and onset of symptoms, and physical examination. Resolution of the rash after drug discontinuation may support the diagnosis, but by no means can be considered as proof. So, for all patients with a suspected exanthematous drug eruption, thorough drug allergy testing, if available, is recommended for confirming or ruling out drug hypersensitivity. Now, on to the management. The first step is to discontinue the offending drug. If the eruption is mild and the medication cannot be substituted, the patient may continue therapy with close monitoring. In addition, the treatment is supportive. For symptomatic relief of skin lesions and pruritus, a topical corticosteroid and an oral antihistamine are suggested. It's important to note that routine use of systemic corticosteroids in uncomplicated cases are not recommended and are best reserved for patients with very intense cutaneous symptoms. Regarding book med versus street med, textbooks usually say to immediately stop the drug and start symptomatic care. But in clinic, sometimes you treat through, which means you continue the medication in the setting of a mild presentation under close supervision, especially for medications without easy alternatives. Here are a few clinical pearls. Number 1. Eruptions often appear 1 to 2 weeks after starting a drug, so always review the timeline when assessing a rash. Number 2. Scaling and desquamation during healing can be mistaken for more serious conditions. Reassure patients it's part of the normal process. And number 3, common culprits include aminopenicillins, sulfamethoxazole, carbamazepine, and clindamycin. Make sure you keep them on your radar. All right, let's test our knowledge with a couple of clinical questions. Question 1. A 45-year-old man presents to the clinic with a mildly itchy rash on his trunk and extremities that began yesterday. He is currently on amoxicillin, which he has been taking for 7 days for a sinus infection. He denies fever, mucosal involvement, or other systemic symptoms. Vitals are unremarkable. Physical examination reveals a diffuse erythematous maculopapular rash involving the trunk and extremities without any desquamation or scaling. What is the best next step in management? Is it A, discontinue amoxicillin and start oral corticosteroids? B, continue amoxicillin and add topical corticosteroids? C, discontinue amoxicillin and start topical corticosteroids? Or D, refer for skin biopsy to confirm diagnosis? I'll give you a couple of seconds. If you chose C, discontinue amoxicillin and start topical corticosteroids, you are correct. This presentation is consistent with an exanthematous drug eruption. Discontinuing the causative drug is the mainstay of treatment. Topical corticosteroids and antihistamines can help with symptomatic relief. Oral corticosteroids are not typically required for mild cases, and biopsy is unnecessary with this classic presentation. Question 2. A 32-year-old woman presents with a rash that started 2 days ago. She denies any contact with potential allergens or irritants. The only medication she is currently taking is trimethoprim sulfamethoxazole for a UTI. She is on day 7 of treatment. She denies fever, mucosal involvement, or systemic symptoms. Examination reveals a symmetric, erythematous, maculopapular rash involving the trunk and upper extremities, sparing mucosal surfaces. Vital signs are unremarkable. What is the most likely diagnosis? Is it A, Stevens-Johnson syndrome, B, fixed drug eruption, C, exanthematous drug eruption, or D, drug reaction with eosinophilia and systemic symptoms, also known as DRESS? If you chose C, exanthematous drug eruption, you are correct. The symmetric rash, delayed onset after drug exposure, and absence of systemic symptoms or mucosal involvement are characteristic of an exanthematous drug eruption. Stevens-Johnson syndrome and DRESS would present with more severe systemic symptoms and mucosal involvement, and fixed drug eruptions would recur at the same site. Great job! Thank you for joining me on this episode of the Pro PA podcast. I hope you now feel more confident recognizing and managing exanthematous drug eruptions. Don't forget to hit the subscribe button and turn on notifications so you never miss an episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.